chronic musculoskeletal disorders are brain-based. Yes, why is it worth doing these courses? Well, just based on the research, it's saying that chronic musculoskeletal disorders are brain-based. Chronic pain is brain-based. Failure to properly recover as an athlete from an injury and then be predisposed to another injury, or potentially poor motor control after the injury, you know, athletes don't want that. They want to be fully recovered and performing at their best again. So if you work with any of those categories of patients, whether it's chronic pain patients, athletes, or patients with any other orthopedic problems, then this is the next step of what you should be learning. That's not my opinion, that's what the research is saying. So I think what the neurology has done is, one, given me a greater spectrum of patients to work with, so all the neurology ones as well as the musculoskeletal ones, but also I feel I better understand the mechanisms behind people's problems. And if you understand the mechanisms better, then I think your therapies can be more specific, directed at that particular problem. And I find it then easier to explain to patients why they've got chronic pain, for example, why they keep getting re-injured, which then helps me motivate them to do their rehab exercises, which will actually then get them properly better rather than just treating some symptoms and then waiting for the next relapse. Okay, so with acute injuries, functional neurology can also be quite useful, simply because you understand better what the mechanism of the injury might have been, and it gives you more ideas of how to comprehensively rehab it. In the very acute stages, you might not be able to do much to the actual injured area, but what you can already start with is rehabbing all the systems that possibly caused the injury in the first place. Maybe the cerebellum wasn't processing proprioceptive information from an ankle properly, and that's why you sprained the ankle. Maybe there was lack of proximal stabilization in that limb where they sprained the ankle, and you can already start working on those mechanisms. So having that deeper understanding that underlies injury mechanisms can help you start rehab programs earlier. So another consideration is when patients present with acute pain, but they didn't actually have an injury that caused it. So these are the patients who say, oh yeah, I woke up with pain, maybe I slept funny. But you ask them and they didn't actually sleep funny. They slept in the same position that they always did. In those cases, you've got to consider that their acute pain is actually brain-based, and that it's simply due to a failure of a balance between two areas of the parietal cortex, one that processes pain and one that processes proprioceptive input. And this brain-based pain is much more likely to happen in sedentary individuals than in active individuals, and is more likely to affect the spinal regions and the proximal limbs, such as the shoulders and the hips, than it would be the more distal extremities. Functional neurology doesn't negate the need for manual therapy, not at all. It works with it. So it's a complementary thing where the two go hand in hand. I mean, a lot of what I do with patients is still hands-on manual therapy. It's just in addition to the manual therapy, I prescribe specific neuro rehab exercises to help then stimulate the correct regions of the brain for that particular patient.
Do you use other exercises as well?
Well, strengthening exercises, motor control exercises, absolutely. Any form of exercise, and encourage general activity for most patients. So functional neurology is not only for neurological problems like concussions or vertigos or dystonias, that sort of thing. It's very much relevant for what you would consider musculoskeletal or orthopedic problems, such as pain. Musculoskeletal pain, it's very relevant for that sort of chronic pain because we look at the areas of the brain involved in pain modulation and try to make them function better. That's one of the big premises that we do in functional neurology for chronic pain. We obviously also look at the peripheral inputs that are causing pain, which would be considered typically orthopedic or musculoskeletal, but you've got to put the two together because a lot of chronic pain is very much based in the brain through lack of pain modulation or pain facilitation that is driven by the central nervous system. So yes, the research is saying that a lot of conditions, there is a problem, let's say, in the cerebellum, in the mesencephalon, in the frontal cortex. And they've got studies that have used functional MRI scans or PET or SPECT scans that will show this. But we might read that research and think, OK, well, that's all well and good, so what do we do for it? Most manual therapists don't have any tools to, one, assess those regions of the brain or treat those regions of the brain. So this is what we do in functional neurology. We look at those areas of the brain, we try and assess them as best we can, and then we give neuro-rehab exercises to facilitate better function in those areas. We can also try and make our manual therapy techniques a little more brain-based if we know which areas they're likely to target, and that's also what we cover in the courses. There isn't enough research to call it evidence-based because there's no protocols in functional neurology. There's no easy way of doing research on functional neurology because there's no standardized procedure to rehab a certain condition. You've got to assess patients individually and then treat them individually. But all what we do is evidence-informed. So for chronic pain, for example, that research has evolved massively over the last, say, 10 years. And when we look at things like central sensitization, for example, they say that, you need to get the patient exercising. You need to get them doing motor control exercises, preferably, to address their chronic pain. And we're looking at stimulating the brain regions that are important to function well to promote good motor control. Everything from normal musculoskeletal patients, especially those with chronic musculoskeletal conditions, and the literature says this, that for chronic musculoskeletal conditions, we need to look at what's happening in the brain and use a more neuro-rehab approach on them to completely get them better. Then there are patients who have had concussions, whiplash injuries, vertigo, dizziness, balance disorders, dystonia patients. Also athletes who've had previous musculoskeletal injuries or concussions to properly rehab their neurological function in order to prevent future injuries. So functional neurology is a little different from medical neurology in that the conditions we treat are more functional than the hard neurological lesions that you would encounter in medical neurology. So we don't use tools such as surgery or particularly drugs to manage patients. Instead, we try to retrain the nervous system using neuro-rehab exercises. So when I was at university, I was very interested in neurology. We were only taught medical neurology though, but I was fascinated by the subject. And I was also fascinated by underlying pathophysiological mechanisms of how things like manual therapy and soft tissue therapy and all these things actually worked. And nobody could really give me any answers when I was at university. So I started looking at, okay, how can I learn this? So when I graduated, I started studying with the Carrick Institute and learnt what they taught as functional neurology, completed that whole program, took their diplomat of the American Chiropractic Neurology Board exam, and a few years later then started teaching this stuff myself.